Well, good morning, and it's morning here for one more minute. So we're going to get ready to start with the Implant Study Club. This is part one, clinical tips for successful implant surgeries. You are going to receive 2 hours of CE credit today. This is all part of the Washington Academy of General Dentistry Stay Home, Stay Healthy CE program. This is brought to you by the Washington Academy of General Dentistry and our partners that include the University of Washington School of Dentistry CE, the Canadian Academy of Restorative Dentistry and Prosthodontics, the Pierce County Dental Society, Seattle King County Dental Society, Snohomish County Dental Society, Comet USA, Patterson Dental. We'd also like to thank the Texas Academy of General Dentistry, California Academy of General Dentistry, and Arkansas Academy of General Dentistry for joining us, for putting our information out there. Just a reminder, this CE is brought to you at no charge. Every single one of our presenters is donating their time, their expertise, and we appreciate it. As you're watching your screen, you'll see that we have a number of events that have already occurred this week. We're just throwing those up there so you can see that these events and the webinars are recorded. You can access those at washingtonagd.org, or you can go to YouTube and access Washington Academy of General Dentistry. So your question will be, is this being recorded today? Yes, it is. If you have questions today for the doctors, please type in the Q&A window, not the chat box, please. We'll try and get to as many of those questions at the end. Dr. Yassin will monitor the Q&A as well, and perhaps address some of those questions as the study club progresses. Just a reminder, at 2:30 today, we've got Dr. John Nosty speaking on to prep or not to prep, preparation, design, and material selection in the anterior, all ceramics. This starts at 2:30. We've got it slated till 4 o'clock. This is an excellent lecture you'll want to tune in for. This is the lecture he did at the Academy of Operative Dentistry in Chicago here in 2020. I've seen it. You're going to enjoy it. You will see that each slide, each flyer has a QR code. You can use those QR codes to register for upcoming events. If that's not working for you, go to washingtonagd.org and you can see a list of our upcoming CE events. These change on a daily basis, so please visit often and see what we have to offer. Regarding CE, all CE credit will be mailed out to the email you registered at within the next couple of days. You'll be receiving that through the University of Washington School of Dentistry Continuing Education. For those of you that are AGD members, we will report your CE credits directly to the AGD, and that should show up on your transcript within 2 to 4 weeks' time. Please be patient with that. The AGD is receiving so much CE credit. Some of our webinars we're hosting over 1,200 people at a time. So just need you to be patient with us. So we're waiting here. It looks like our numbers are stabilizing with who's signed up. Everybody seems to be getting into Zoom okay. A lot of times we get questions about the view. You're going to need to play with your Zoom application a little bit. Up on the upper right-hand side, you will have a control for gallery view and speaker view. So you can toggle that on and off for whatever you prefer. Also, our speakers will be sharing their PowerPoint presentations. And those PowerPoint presentation, this presentation will be recorded and it will be on YouTube in the next couple of days. That should cover all the details. Oh, we got a question and answer already. if you see the recorded version, do you get, no. We're working on that. If you watch the webinar on YouTube, we're not doing CE credit at this time. So thank you for asking that question. All right. It looks like the majority of participants are in our webinar. So again, welcome to the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. It gives me great pleasure to introduce Dr. Alan Yassin. And part one of the Implant Study Club he's put together. This is clinical tips for successful implant surgeries. You will receive 2 hours of CE today. Don't forget to sign up for part two on Monday, April 20th. Dr. Yassin, I'm going to stop sharing my screen, and could you please introduce your guest?
Yes, absolutely. Thank you, Dr. Hess. And here we go. Let me go ahead and share my screen here. I think it's working good, right?
Yes, working really well on this side.
Perfect. Thank you, Dr. Hess. Thank you, Dr. Mayhaireh, for joining us today. Welcome, everybody, to the start of the Implant Study Club. This is an online weekly meeting we designed through the Washington Academy of General Dentistry to start mainly at noon for 2 hours. We have 5 sessions already planned, and every session we're gonna be having a guest. The dates are today, April the 17th, April the 20th, April the 29th, May the 8th, and May the 13th. We are doing this broadcast actually from the beautiful city of Goodwill, Seattle. So welcome everybody from all over the globe. I know we have a lot of attendees going over, coming to us to attend all these webinars from all over the world. Today, in the first session, we have a very special guest, Dr. Hasan Madeira. He's joining us from the UK. Welcome, Dr. Hassan.
Hello, hi there. How are you doing?
I'm doing really good. Thank you so much for accepting my invitation to join us in this great webinar, and looking forward to it. Dr. Hassan is, he's in the UK, as I mentioned. He's an associate professor at the College of Medicine and Dentistry at the University of Birmingham. He's a clinical teaching fellow at the University of Manchester. I believe you graduated from the University of Manchester as well. And he is the head of the scientific committee of the British Academy of Implant and Restorative Dentistry, BAIRD. Well, welcome, Dr. Hassan. Thank you so much. I know you've been so busy. You had today an online meeting all day. Probably it's the end of the day there in UK time. So thank you so much.
It's a pleasure. Thank you. Thank you for the kind invitation.
Yeah, tell me, how is all this online things going on? I think it's really amazing what you're doing. You guys have been watching you, and you're doing a great job.
Well, I think, you know, it's tough on everyone. Us dentists, we're very passionate about what we do. And obviously we've been asked to, you know, put our tools down. So it's up to us to be positive or negative about it. And one of the things we decided to do is to, you know, use the social platform, Zoom platform, which are things we used to know nothing about 4 weeks ago. But here we go. I mean, we had a congress last week for our academy, and we had around 45,000 participants from all around the globe. And as we speak, we have another congress in collaboration with the Saudi Dental Society. And today was our second day. We had very good speakers from the States. We had Dennis Tarnow. From Switzerland, we had Danny Boozer. And I think it's a good way to stay together. Obviously, this COVID-19 thing is very disrupting and annoying. And the only thing we could do at this time is to come together as a dental community on a global level. To that extent, I'd like to thank you for what you're doing. I mean, what you're doing is highly commended, moving your Implant Study Club online, which is amazing. And, you know, you and the team are highly commended for that, my friend.
Well, thank you so much. As you said, it's hard time for everybody, and we are trying just to keep it up, take the best out of it, and eventually, I know everybody discovered that we are a strong dental community, thanks to everybody who is really serving and giving this great services, great online CE courses. I've been spending a lot of time watching, colleagues from all over the world. And it's my pleasure actually to start this study club, which is, it's really something unique. I wanted just to talk a little bit about it. It's mainly a clinical study club. So what we're going to be doing today is it's 2 hours of talk. I'm going to start with sharing some of my thoughts about surgery. I'm a surgeon. I'm a dual trained in both periodontics and oral surgery. So I'm heavily surgery oriented. I know Dr. Madeira has also restorative background, Dr. Hess as well, he has restorative background. So it's gonna be a discussion if we can just go back and forth and share our knowledge. I would encourage everybody to reach out to us, to Dr. Hess or Valerie right now, if they wanna share any of their cases with us. We can give you ability to share your screen, and then you can discuss this with us, making the top of this thing just to make an advantage of taking advantage of this great seminar. So thank you so much. I'm going to start with pretty much brainstorming things. I know Dr. Madeira has a great background with aesthetic implant dentistry, implant in the aesthetic zone. I personally attended a couple of his courses online. We've never met personally, actually. So this is how it's amazing that this world is just a small village right now. We know everybody, and you think that you've been knowing them for a long time. So it's amazing, right?
Great.
So, I want to start with this slide of us. I start with this just to share how complex the dental implants are in general. We always hope that implant dentistry in 2020, after 40 to 50 years of doing implant dentistry, is going to be as straight as putting an implant and restoring it, and that's it. But unfortunately, implant dentistry is really, really a complicated things. We need to make sure that we are doing a lot of studies before placing our implants. Implant cases are not straightforward. We face a lot of cases with either soft tissue management, soft tissue deficiency, hard tissue deficiency, sometimes engagement with some vital structures. We have our IAN and the mandible maxillary sinus as well. Sometimes we will be forced to discuss some of the pathology when we have some cancer patients, a mandibulectomy, maxillectomy. A lot of time we are talking about full arch solutions. So it's pretty much, it's something I wanted to do this implant study club to different levels. So somebody who is starting the implant dentistry career right now with very minimum experience would have something in this study club, all the way to the specialist who's been doing some advanced stuff in the past years and with really advanced levels of implant dentistry. So I hope we're going to be covering almost everything for us. My main thing in this part one of the implant study club is we'll be discussing some of the main concepts in implant dentistry, thinking about three of the big topics in implant dentistry. Bone augmentation is the first one, when we need to put our implant in a good bone housing to make sure that we are having enough support for our implant, supporting the bone to implant contact as a basic concept. The aesthetic zone, Dr. Hassan has great experience with this. I want to take a moment after I finish my small presentation to pick his brain about this and learn some tricks from him, and also the soft tissue management topic as well. Dr. Hassan, in your practice in UK, I know there's, as I said, through the social media, through the internet right now, you feel like the world is really, really a small village right now. But I know the culture is different, sometimes the implant practice. How does this three big topics really reflect in your daily practice in implant dentistry in general?
I think it's spot on. Yes, UK is across the pond from the States, but as you've just said, social media making the whole world as a small village. And the challenges I face, I'm sure they're very similar to the challenges you guys face, and the expectations of our implant patients are the same. I totally agree with you. When implant dentistry started, it used to be whether the implant will integrate or not. But nowadays, we fully understand that sometimes we wish that implant did not integrate because it was in the wrong position or with very little bone around it, and it's hard to replace it with a new one. So these three topics are, I would like to call them nowadays, the ABC of implant dentistry. I get my younger colleagues who are joining our academy asking me, how long would it take them to be able to produce an aesthetic implant? And I think the answer is you could do it immediately, providing you follow the basics, you understand biology and evidence-based implant dentistry. You don't need to be someone with 10-year experience to be able to provide something looking natural. I think nowadays we're lucky. Unlike our colleagues who started practicing implant dentistry 25, 30 years ago, they had no clue what they were doing. Nowadays, the evidence, the literature, the clinical experience is massive, showing us it's so easy. If we follow certain principles, we can achieve what our patients expect us to do. And these 3 points, bone management, aesthetic zone, soft tissue management, are the spot-on points which every implant dentist should know as ABC implant dentistry.
Yeah, well mentioned. Thank you, Dr. Hassan. Exactly, it is the same thing. And this is the small tip. The longest you practice implant dentistry, the more you know that you don't know, right? So it's really important for us to keep this up, make sure that you are getting more education. Personally, I'm a student to the end of my career. I learned from every single case of mine. It's really important for us to understand this concept, like when we are talking about both bone and soft tissue. This discussions, I attended several meetings in the last couple of weeks. I wanted to link this together. Whenever we are preserving tissues, we are preserving bone, and whenever we are preserving the bone, we are supporting the tissue. So it is a link between each other. So whenever we have nice attached gingiva keratinized tissue, we'll support the bone underneath, and whenever we have enough quality and quantity of the bone, we'll get good soft tissue as well. This is one of my best slides. I started my career actually as an oral surgeon. I practiced for almost 10 years. Back in the days, I was heavily engaged with a lot of facial trauma. And, for a maxillofacial surgeon, probably the small details are not in their mind, right? They did not really get a lot of small details in training, right? It is different perspective, exactly like the periodontists, they don't know about the facial trauma. So when I get back to the University of Washington and I started my perio residency, I started to discover a little bit more about this great combination between the soft tissue and the bone underneath them. So this slide, I just always share it with my students and with my colleagues, just to make sure that we know. This is a case of tooth number 7, missing the maxillary lateral. And we are planning mainly to do a straightforward implant, but spending some time to know exactly what's going on in the tooth next door in the canine, tooth number 6 with some recession. It's really important for us to understand the difference between what we are calling the attached gingiva, which is some really thick tissue, and it's non-mobile attached to the bone underneath it, keratinized tissue could be attached or not attached, depending on the situation. Like here, when we have a sulcus, the tissues are keratinized. It's more like the concept of the keratinized tissue is different than the attached gingiva. The recession happening around the tooth will expose everything from the CEJ, the cemento enamel junction, will get to the point that we are adding the recession and our sulcus to our measurements to get how much soft tissue we lost around the tooth. And obviously above the attached gingiva, we have the mucosa divided with the mucogingival junction. So it's something really basic to go back and cover it as we did in the dental school, but it's really important for us to understand those small basic of terminology between what we call it basics in implant dentistry. I want to deliver this message first and foremost. The most important thing in implant dentistry to get your mind in the conservative surgical approach. As I always say, the best surgery is less surgery. And if you're going to be doing surgery, you need to know how to do it. And before knowing how to do it, you need to do when to do it. The best surgeon is the one who can avoid surgeries or who can do minimum surgeries. So this is the big message I want to deliver at the very beginning of this lecture. And I know Dr. Hassan has the same perspective through his surgeries and through his courses, especially that he is doing a lot of work on the aesthetic zone. So any comment, Dr. Hassan?
100%. I think as things progress, our patients' expectations getting higher and higher. And as we said in the past, it used to be all about the implant. Nowadays, it's about the pink and the white aesthetics. And I think furthermore, it's about trying to achieve everything minimally invasive. Because, you know, if you ask patients, why do you like this specific dentist? Usually the answer would be that dentist listens and that dentist did not give me pain. So from our perspective, we want to give them the best papilla, the best pink aesthetics, the best surgery. But we need to remember from a receiving end point of view, our patients would like to have minimally invasive surgery. And I don't blame them for that. If I was in their place or in their shoes, I wouldn't like to have big surgeries when I can achieve the same results at a fraction of time and trauma. So totally in agreement.
Right, absolutely. So it's this is the big message. I see a lot of fresh graduate dentists just jumping into doing surgeries. I heard somebody talking about big flaps to be a good surgeon, which is probably when I first started my surgical career, it was something that I wanted to do. But now, whenever I do more surgeries, I know that more conservative surgery, less surgery is the best surgery for sure. So we are on the same page. Back to this small case, when we have this kind of pretty much it's in the aesthetic zone, tooth number 7. You take a look. Sometimes we think like, let's do less surgery. Dr. Yassin said, let's move with only placing the implant, or we only want to do like 3.0 millimeter implant. We have enough bone. We have some resorption. Let's go ahead and do it. And the answer is, in this case, we need to look from different perspectives. Less surgery does not mean that we just need to ignore the fact that we have some issues in this. We have horizontal bone resorption. We have soft tissue deficiency. We have recession going on tooth number 6. So when we are talking about conservative way of doing surgeries, that does not mean we want to go directly to the last result and placing the implant. We need to think about the final restoration and the final crown over this implant. So instead of talking about osseointegration around the implant, we need to have long-term implant that will serve this lady in her 20s probably for another 60 or 70 years. So the best approach is to think about, let's go ahead and rebuild our soft tissue and make sure that we are getting thicker, nicer attached gingiva that we discussed at the very beginning. We can work on covering this recession, getting better support for our canine. And as I said, soft tissue will give us good support to the bone and vice versa. After doing our soft tissue, which is nice, good technique that will give us probably a good result in 8 weeks, we will be ready to jump into the step 2 before getting into the implant placement. The case after 8 weeks, we already had nice, thick, attached gingiva, will support us with good bone building because we already have almost only 3 millimeter of bone. We need extra 3 to 5 millimeter of bone to be able to place our 3 to 3.5 millimeter of an implant. So it's really an important thing to think both ways. We are thinking about aesthetics and function, and most importantly, we're thinking about the final restoration, and we're coming back to think about implant. This does not really apply only for the aesthetic zone implants. It does apply to all cases in implant dentistry. At this stage, we will be super ready to go ahead and do again our bone graft. As you can see, thinking outside of the box, it's not about just doing less amount of surgery. It is just to do really strategic surgeries. Know exactly how you do your steps in doing surgery, building the soft tissue, getting down to the second stage of rebuilding the bone. Now we have this big question, are we going to be able to place the implant and the bone simultaneously? Obviously, we need to make sure that we have enough bone to implant contact and we have enough initial stability to help us to place the implant and the perfect restorative position to do the final restoration. So in this case, I staged it. I had to go ahead and do 2 surgeries for bone grafting, coming back again to place our implant in the next surgery. I always do this conservative flap design, and and a lot of time, probably the most important surgical approach is to go ahead and learn the flap design and flap reflection in your basic surgical skills. So it's really important for us to, for example, in the aesthetic zone, work on some papilla preservation cuts, make sure that we are not really going into the attachment between the soft tissue and the adjacent teeth. Make sure we have enough release for our flap to be able to do good primary closure for the bone graft above it with a tension-free closure. I had my small technique to do the bone graft. When we do our courses here in Seattle, we always learn how to do the bone graft with minimum traumatic concept, also with more tension-free closure for the flap. So we spend some time to learn how to do this horizontal mattress suture with the flap to be covering the membrane and the bone graft. I have this technique where I place my horizontal mattress suture at the very beginning, place my membrane at the second time, and then do my bone graft, and then tuck everything down with one shot. It's better than going bone graft, membrane, and then the suture. Any comment about bone grafting in the aesthetic zone, Dr. Madeira? I know the concept of having decortication, primary closure, tension-free is really an important concept for us.
100%. And what I would like to add, membrane stabilization. I see a lot of my younger colleagues, they put the membrane and they just close on top of that, hoping for the best. But as you've just mentioned, it's important to stabilize your membrane, whether you're going to use sutures or stabilization pens. I think in more than one study, they showed you get more bone regeneration and better remodeling if the membrane is well stabilized. If you don't stabilize the membrane, you're going to leave it to 50-50. Is it going to work? Is it not going to work? Because you really don't know what's going to happen to that membrane and the bone underneath once you suture on top of that. So spot on. I like what you've mentioned, cortectomy, because obviously we need to get blood supply coming from the bone marrow. We'd like to have all these good osteogenic cells coming from the bone marrow. You cannot put dead bone on cortical plate because cortical plate is rigid. So I do that. And I also like the fact that you mentioned, I put a membrane, stabilize it, and then pack the bone underneath. I found this easier, less messy, and you get you better results.
Absolutely, yes. Stability is the number one thing, and the goal is just to proceed with having the final results with good stable implants, good restoration. In this case, the color is a little bit off, but in general, the papilla are preserved, the bone are supported, and we have really good housing for the implant. So what I meant by the best surgery is less surgery does not mean that we do try to push the limits. We try to study the cases in general and know exactly our steps. Probably if I've done this surgery 20 years ago when I first started my career, probably I will do it in a different way just to try to combine stuff. But taking it step by step is really important. It's something, it's something amazing for me, because a lot of time we have different patients with different aesthetic and functional needs. So I always, this is my neighbor. Well, he's a great guy. I've known him for several years. One of the days back in the day, I saw his big smile for the first time, and I saw this big, huge metal in his mouth. I did not know what is it, and then I asked him about it, and it ended up to be an implant, and it's been there for almost 20 years, since the 1990s, and he has no aesthetic problem with it. He has no functional problem with it. And as you can see here, this is an implant. It looks like it was placed as an immediate implant. It's too deep. This is the abutment, and this is the crown. Nothing is good about this implant, but the patient has been more satisfied than any other patient that I've known. That does not mean that we can encourage this practice, but at least we need to understand that patients are different in their needs. Are they really looking into aesthetic results? Are they looking into more functional results? We work on either to give the perfect smile for patients or sometimes to restore their own smile. Some patients will be more than satisfied with this. Before jumping into our discussion, I just wanted to mention how the concept of less surgery is the best way to go, because even when you are a general dentist or you start your career, you need to understand that soft tissue is really important, not only in the front and the aesthetic area, but also in the back. Learning some tips like doing some root coverage techniques, connective tissue grafts, using some the cellular dermal matrix techniques, doing some of this tunneling technique to rebuild our soft tissue is really a good practice to learn and to develop your knowledge through your implant career. I know a lot of general dentists, they focus only on placing implants, which is not really the best practice, because you need to understand how to do bone grafting and soft tissue management around your implants. It's not about only taking impressions and doing your surgical guides and placing an implant. We are past this point. We need to think about the whole concept. So those techniques like, rebuilding some of the connective tissue graft to a tunneling technique to rebuild around our natural teeth will help us with getting better results, not only about the implant, but also about the adjacent teeth. For me, when I talk about a conservative way of doing it, it's really important for us to think out of the box. And whenever we are doing some soft tissue, better than doing full thickness flap, reflection, big flaps, trying to do it to the minimum and try to use this tunneling techniques that I always use to sneak my soft tissue graft. In our soft tissue management courses that we provide, we teach this heavily. And eventually you will see that it looks like it's so complicated of the case, but it's something to learn, and as long as you practice more, you will be more confident with doing some of this soft tissue work. There's some tricks in doing some suturing, stabilizing, as Dr. Mayhaireh just mentioned. Not only in the bone graft, stability in every single surgery is the key for success. So finalizing the case with doing some suturing, putting everything nicely together will just lead for putting our soft tissue underneath, and then finalizing the whole thing with a couple of sutures to support our bone graft, our soft tissue. And eventually we will end up with nicer, thicker soft tissue with root coverage to support our, not only the natural teeth, but also in general the implants around them. Dr. Mayhaireh, what do you think about this thing? I know this is something advanced. A lot of people will say this is a periodontist work, not a general dentist. Personally, I do believe that anybody who is in the implant world need to advance their skills and make sure that they know how to deal with simple, straightforward to advanced cases. What's your take for this, especially with you doing a lot of courses for general dentists?
No, 100%. I mean, obviously, when you have a patient coming to you, whether they have one missing tooth, like the case you've shown us earlier on of that lateral, you've placed an implant for that lateral, but the canine next door, I notice you've done some soft tissue management for the tooth itself. You know, patients don't really come and say, right, I just want an implant. They want to feel better. They want to look better. And if you're gonna do an implant surgery and there is a recession on the tooth next door, that would be the perfect opportunity for you to go on with that. But may I ask you, would you talk to us about, did you need to do any management of the tooth structure before putting that connective tissue graft in this tunneling technique?
Yeah, this is absolutely, this is amazing. Whenever we are talking about root coverage, it's really important for us first to make sure that we don't have any active periodontal disease, right? The second thing, if we have any restoration on the tooth, we need to consider it. Highly likely, we can't really expect the connective tissue graft to attach to any restoration composite, so we need to deal with this. In this kind of case, usually what I do some mechanical preparation, especially that the teeth, we have recession. One of the cases is just because the whole housing of the tooth is pushed onto the buccal side. So I did some mechanical preparation. I do some of the etching. I use mainly the etching acid and the EDTA to prepare the site to receive the soft tissue, and the enamel matrix, the Endogain is works great actually to support the surface and before putting this. So it's mainly three combination of mechanical cleaning, mechanical, and chemical support with the addition for the growth factor to support this adhesion between the soft tissue and the roots underneath it. Yeah.
Right. There was a question here from Jimmy asking you, was it harvested connective tissue graft or was it alloderm in this case?
This was a connective tissue graft harvested from the palate. It's not a soft tissue course. I can share this down the line. But in this case, I think let me see if I had the slide down there. I collect this and my technique actually from the palate. You know, when we have the palate is a great resource to have a connective tissue graft. We have the regular way of doing the soft tissue collection with the trap technique, just doing our incision and take some tissues from underneath and do the suturing on it. This is how we learn in our perio program. Most of the periodontists, they do it. For me, I noticed that one, we are getting poor quality of the tissue. We get a lot of fatty tissue from the underneath. We are going too deep. We have a lot of vital. We have the greater palatine artery and the nerve here, so we can make more damage. And we will end up with almost 40% of the cases with a sloughing on this. So I was thinking of why we not take the superficial way of the tissue, eliminating the epithelium. And of course, it's really known to everybody that Dr. Zucchelli technique with getting all this nice tissue from the outside. Exactly like this, you get almost 1.5 nicely millimeter of it. For me, I just modified the technique. Instead of doing the deepitalization outside of the mouth, I use this small trick, doing this wheel-shaped diamond to deepitalize the graft intraorally before collecting the graft. Simply, it's going to be nice tissue. I tug the old site with some kind of collagen membrane, and I use the suck down stent to help the patient. Usually patients will come with no discomfort using this stent to cover it. And you can see that we have nice tissue quality for this. So it's not a course, or it's not really a lecture to teach how to do the connective tissue graft, but it is a great question for us to answer. So thank you, Dr. Hassan, and thanks for the question. Any comments from you for the root surface preparation before doing any coverage or root coverage?
Yeah, personally, we would like to remove any, because we've got some questions here from Dr. Chang and Dr. Nadeem. They were asking, would you remove any composite fillings like class 5? And I think the answer, as Alan just mentioned, yes, I would remove the filling and clean the tooth surface because obviously no soft tissue will attach to a filling, a composite filling, whatever. And I like what you've mentioned about taking a full gingival thickness, because that will help you to get a uniform soft tissue graft. Because when you get the trapdoor subepithelial connective tissue, it's going to be very tricky to get a uniform thickness. And then when you try to adapt something which is pumpy, like up and down, there might be some spaces for hematoma. Hematoma means bacteria necrosis of your soft tissue graft. While when you take it as a full thickness and then you work on it, make it nice and smooth, I think you get better results. Yeah, the same approach we follow in our practice.
Absolutely, I agree. Thank you so much, Dr. Hassan. I wanted, in the middle of this, I wanted to, I've been working with the Washington Academy of General Dentistry for several years right now. I want to give a lot of credit to this lady, Valerie. She's our executive director. She's been doing a great job through the years to support everybody. So thank you, Valerie. She's on the panelist list right now. She's supporting us.
Thank you, Dr. Yassin.
Yeah, thanks, Valerie. Again, going back to our idea, and then I just want to share a couple of things, random thoughts for me before Dr. Hassan take over. Please, everybody, if you have any questions, feel free. We are getting great questions. If you want to share any of your cases to discuss treatment planning, that would be great. Some of my students in the course, the dentist students, they are already here. They're gonna be sharing some of the cases to discuss. We have a great group going on now in Seattle. So I call them my brothers and sisters, the full-timers. We've been spending a lot of time in this course. So please, if you feel free, if you want to share any of the cases, go ahead, contact Dr. Hess or Valerie, and they can give you an access to share knowledge, to share the screen. The second thing is how, when we do the osseous augmentation, when we want to do more bone grafting. And if you think about it, we do bone grafting and implant dentistry in three different situations. Either when we do the extraction, the same time of the extraction, we call it the ridge preservation, socket grafting, just to try to preserve as much bone as we can. The second case is we do it simultaneously at the same time of implant placement to support it as much as we can and give better bone to implant contact and the support for the implant. And the third situation is when we go ahead and build the bone or the ridge before doing the implant, especially if we have really severe atrophy or bone resorption. So this is the main three cases. And as Dr. Hassan mentioned at the very beginning, stability is the most important thing in bone grafting building. We have 3 days course of bone grafting, osseous augmentation, and implant dentistry. And everybody attended this course knows that this is one of my favorite slides. And I want to go through this 9 essential principles to build bone with you. I thought about it for a long time, but this is what I give it the Yassin tent concept, because this is what we need to think about when we are building bone. First thing, we need stability of the bone graft, no mobility, including the bone graft and the membrane above it. And if you think about it, it's similar to the tenting effect with all these 9 principles. Stability of our tent when we're going camping is number 1 important thing to think about. Second, space maintaining. We need some support for our material, no collapsing for the tent, no collapsing for the tissue over the bone graft. Materials or the membrane need to be stabilized and maintained. 3, isolation from the surrounding tissue, which is the barrier. This is how we have really thick, nice tent material to support and to isolate us from the surrounding weather and the surrounding atmosphere. 4, perfect seal from the outside effect. We need to make sure when we do our tent and camping, we need to make sure that we have closure, primary closure around us. We don't really need to have anything to sneak inside our tent. 5, contained environment. We can't really have a loose environment around our tent, exactly around our bone graft. Blood supply, which is the most important thing for our bone grafting, which is similar to our nutrition to survive in our tent. Either we're gonna bring something with us or somebody will need to keep bringing some of the food and all this good diet for nutrition for us to follow. 7, firm contact with the underlying base. We can't really expect to put some bone without really a contact with the bed underneath it. So we need to make sure that this bone is contained and we have some contact with the biology. We can't expect to grow bone without really some support from the body. Similar to the tent, we can't really put a tent on a slip. We can't put a tent on rocks. This is why we try to find a nice, straight, firm base for our tent. 8, clean environment. We can't really put a bone graft on any infection. A lot of time we'll think about putting some bone graft in the granulation tissue area, which is, we can't really expect bone to grow in any soft tissue surrounding them. Similar to our tent, we can't put it in a stinky, bad area. And 9th, which is really important, we need to have the material, something to grow bone, osteogenesis property, either bone graft or even blood clot, that will help us with building the bone. So thank you, Dr. Hassan. Already at the very beginning, you hit it right on this. It's really important to get this stability. I try to just summarize these things with my brainstorming. It's working really good for me. Any thoughts about it?
No, I mean, definitely. When it comes to guided bone regeneration, it's important to follow the rules, the guidelines. Otherwise, it's going to be waste of your time, your money, and your efforts. And it's shocking how some of our colleagues, they think, you know, guided bone regeneration is all about getting a membrane, shoving some bone underneath, and that's it. you know, as you've rightly so alluded to, the importance of stability, the importance of making sure there is good blood supply coming to the area, proper soft tissue closure, and the 9 principles in your tent concept. I like it very much.
Absolutely great. Thank you so much. Yes, so we can expect to have bone graft either by simple horizontal bone augmentation like this, which is, as we know, the horizontal augmentation is way more predictable than doing some vertical augmentation. We need to think twice before putting our cut or incisions. Make sure we are thinking about this 9 topics, 9 concepts that we discussed for bone grafting, stabilizing the membrane, building the material to you know, access this result of placing the implant with enough stability, enough bone to implant contact, good restorable position, make sure that we are choosing the right fixture and you know, support our implants and the soft tissue at the same time. We could go all the way to more advanced cases, and it's not probably the case for general dentists to deal with, but we face those advanced cases also when we build really severe loss on the bone, similar to trauma patients. This patient was a facial gunshot. We ended up doing a big first surgery for him, and probably for 8 hours trying to put things together, soft tissue. But the patient ended up with really severe bone loss in the mouth. And sometimes we don't really, we will not be able to build some bone with some simple, straightforward, resorbable membrane or some particles membrane. We need sometimes to think out of the box and to get the autogenous block graft, which is, for a long time, it was the golden concept for building the bone, either by collecting intraorally from the chin or the ramus, or extraorally from the rib or the fibula. So some kind of advanced techniques, doing some bone grafts all the way from the chin, taking some the full thickness with the cortical bone. Luckily, this patient at the surgery, we ended up with really good healing at his face, and he just actually contacted me a year ago, told me that he got married. So we're lucky with those kind of techniques to learn. It's really important for to know our limits. So at one point, if we were not able to provide this surgery or provide a good service for our severely atrophied anterior area, working with an interdisciplinary approach with our specialists, with our friends, is really an important skill to make sure that we're providing the best service for our patients. As I mentioned before, in our course and our clinical implantology from A to Z, we in 2019-2020, it was nine sessions. In 2020-2021, it's going to be 10 sessions. We learn all this advanced techniques. So we have live surgery. Even our doctors, they try to not only do straightforward cases, but some of the sinus augmentation, bone augmentation. So take a look if you are interested in advancing your knowledge. Let us know. We help with a lot of online lectures, online meetings. We make sure everybody's taken care of. I know, Dr. Hassan, you have, it's really a nice topic for you, and probably in 5 minutes I'm gonna give you the chance to share your knowledge with us and with your presentation. But another alternative way of doing some bone grafting is this advanced way of doing prefabricated, customized allograft block, which is a CAD/CAM technique instead of doing our autogenous blocks that we usually do in our severely atrophied cases. The prefabricated, customized allograft, it's mainly computer designed, computer fabricated bone grafts. It's allografts from donors. We try ourselves to go ahead and Dr. Hassan is back. I know this is one of your great topics to talk about. I was talking about how to manipulate bone graft building through either autogenous bone graft or through this prefabricated customized allograft. I know we have this discussion before. We talked about it, and I've been doing a lot of cases. I've so far so good for me. I'm getting some good results. In this case, a young lady with a severe, bone loss in the anterior maxilla. This is exactly the design for the bone graft, and we start obviously when we're designing the final restoration. We're planning to have 3 restorations at the end, and from there we kind of follow implant placement in the perfect position to follow the ideal restoration for it. And then we see on this planning, we see exactly how much bone we need to support this bone graft. So we proceed with covering this bone graft with this implant with more of bone material, and to make sure that we have enough bone to implant contact when you place the implant, better support not only for the bone but also for the soft tissue. And then we virtually fabricate our bone graft on the software to make sure that we have the nice block. Starting from this point, as you can see, if you want to eliminate everything, we can end up with the bone graft itself. Mainly we make sure that it's supporting the implants at least for 2 to 3 millimeter. We expect some resorption after this allograft placed, somewhere between 25 to 35% of the bone graft. So a lot of time we overbuild this as a design to make sure that we have enough of this block. And as you can see, we can end up with a nice block on the software that we can send it to the computer designed right now. We can send it to be computer formed and fabricated, and we can end up with just a use for a block as allograft from donors working on a nice block. We can go ahead and do it as really good firm stability, because it's really adapted to the underneath tissues, will be easy to place, screwed with rigid fixation. It is I think one of the most important advantage for this technique is the adaptation with the bed underneath. Remember when we talked about the importance of having this adaptation? A lot of time with the autogenous blocks from the chin or from the ramus, we will not have this adaptation. From this kind of prefabricated customized allograft, we will end up with some kind of better adaptation. And then we come back in 6 to 9 months. You can see how the bone quality, the quantity of the bone is really important. In this case, I just utilized some of the zirconium implants, and it was guided surgery. Go ahead, placing the implant, pretty much nice bone quality and quantity and the case, and it's an alternative way of building bone, considering all these 9 concepts to go ahead and do our bone graft. If some people, they did not really receive enough training to collect some autogenous bone graft from either blocks from the intraoral or extraoral resources. So this is an option for this. I know me and you, Hassan, we talked a little bit about it, and I know that you had a lecture a couple of days ago about this technique. So any thoughts about it?
Yeah, definitely. It's I think this is the I wouldn't call it future. It's a reality now, where
right.
Not only we are saving our patients the trauma of harvesting a bone block from their body, but also saving the time and the duration of the surgery by 2/3. As I will mention in my talk next, You know, whenever you want to do bone graft, you've got three challenges. The first challenge is to harvest a good piece of bone. The second challenge is to adapt and shape and contour that block so you can get precise adaptation. And the third, and believe it or not, this is where people usually struggle, is to get proper soft tissue management and proper tension-free closure. Now imagine if we have the technology, and we have it now, where the two challenges being dealt with before starting the surgery, and what used to take 45 minutes in the hands of very good surgeon will take now 45 seconds in the hand of general practitioner. And then all what we need to do in the next 45 minutes is focusing on having proper soft tissue management. So definitely, I think, you know, the fact that it is a bit costly, but if you explain to the patient that this will reduce the time of the operation, increase the success rate of the surgery, and make it an easy operation, I'm sure it will be easy to sell.
Absolutely, absolutely. It's as you said, it's not the future; it's happening right now. And of course, we have a lot of knowledge to learn about it. It's just something from the advances that we already have. And I know that it's one of your favorite topics. So I just wanted to summarize the 3 points: bone grafting, soft tissue, and mainly the aesthetic zone, just in our discussion in our implant study club. To open the discussion for you, I know you have a great lecture right now. If you have any questions, I'm going to be running the question and answer while Dr. Hassan. I'm going to stop sharing my screen, and you are absolutely ready to rock it. So it's all yours.
Thank you.
Thank you.
Let's have a look. Okay. Right, can you see my screen now?
Yes.
Perfect. So good evening for people who streaming from Europe, and good afternoon for all the good friends in the States. Once again, thank you, Alan, for your kind invitation. It's a great honor to be here with you today. And this is the beauty of you know, social media. You know, us in Europe, you guys in the States, we're having the opportunity to exchange our experiences together and being positive at these tough times. So as you've kindly invited me, I'm gonna talk for the next hour or so about bone management or bone augmentation in implant dentistry. And I am involved in universities, so I do teach at the University of Manchester, where I had my postgraduate training as an implant dentist. I'm also an associate professor at the College of Medicine and Dentistry, Ulster University, which is based in Birmingham in the Midlands. And I'm proud to be from Leeds. I'm also the head of the scientific committee of the British Academy of Implant and Restorative Dentistry. I've published some research, random controlled trials, systematic reviews on PubMed, with a special interest of soft tissue management and bone grafting in implant dentistry. But primarily, I'm a dentist, I'm a clinician who work in dental practice limited to implants. And I'm so lucky to work, I wouldn't call it a big team, we're a small team, but we like it because this way we provide our patients like absolute patient-oriented service. We keep it personal. I work with my colleague, Dr. Victoria, who's a young rising star implant dentist. And I work also with my implant coordinator, Victoria. The only slide you're gonna see in this presentation, which was brought to you by the power of Photoshop, is in the middle one, because I promise you they did not write that in their slides. I photoshopped. We love working with Hassan. I'm also lucky to work with a very good technician in the United Kingdom, Jonathan, and another good, very good technician in south of Italy, Guglielmo. So most of the all of the cases you're going to see, a credit goes to Jonathan and Guglielmo. And what we do, as I'm sure you all you share the same value, or everything we do is trying to achieve positive patient outcome. Us dentists, we do, we do want to get a positive patient outcome. This is what inspires us. This is what gets us out of the bed in the morning. Otherwise, job and work will be very boring. This is my Instagram, Hasan_Madeira, and you've got Victoria's and Laura's Instagram. If you like to get in touch with us, discuss cases, or even ask for a PDF summary of this lecture, we'll be more than happy to get in touch with you. Now, dentists, surgeons, periodontists, general practitioners, we do get what we call bad day in office. And this is Sarah, who went to have implant treatment by one of our colleagues who had a bad day in office, went in, placed an implant, implant well integrated, but Sarah, who's only 20 years old, wasn't very happy because, as you could see, we've lost the papilla mesial to that tooth. Obviously, from our point of view, in 2020, this is unacceptable. Another bad day in office case, John, who had an implant about 4 or 5 years ago by another colleague of mine. And with time, you could see we start to get bone loss and soft tissue recession. This is totally unacceptable. And obviously, we need to make sure we avoid that. All these cases, Emma, Margaret, our patients I've seen, they had implants and things went wrong. And Nicola is a case actually I Googled from Google, and you could see all these cases, people had well integrated implants but in the wrong position. Now you could say as an average dentist, you could say, well, do you know what? These teeth are well stabilized. It's not the end of the world. But none of us wants to be an average implant dentist. In fact, you guys, ladies and gentlemen, you've decided to sit down in front of your screens and leaving families, kids, children behind you, and you decided to come and join this webinar because none of you want to be an average dentist. And this is what we should all work on. We shouldn't be just focusing on trying to finish the job as quick as possible, get the money of the patient and move on. What we need to do is to make sure that we're above average. Average is not good enough. We want to be the best we can be. And as I've mentioned at the very beginning, whenever one of my younger colleagues come to me and say, right, Hassan, how long would it take us to be able to achieve a nice papilla between two implants? How much experience we need to have? My answer is, actually, you don't need much experience as much as you need to have proper training, proper mentoring, and then you could follow the system and achieve great results from the very beginning. It's up to you to decide whether you want to be an average or you want to be the best you can be. It's a decision only you can make and accordingly decide how to progress. Personally, I don't believe there is a bad implant dentist or a bad general practitioner. All of us worked hard to get to where we are at the moment. The difference is being passionate, being obsessive, and opposite to that, being indifferent. Again, it's up to you, only you can make that decision, whether you want to be passionate or obsessed or indifferent. When it comes to implant dentistry, as Alan rightly so alluded at the very beginning to, we have to focus on soft tissue. Pink aesthetics is the major thing in implant dentistry. Urs Belzer, who's a very famous prosthodontist from Geneva, makes it clear at the very beginning that if you get pink aesthetics right, white aesthetics can be easily achieved. If you fail in the pink aesthetic stage, having the best ceramist, the best technician will not save the day. And when it comes to pink aesthetics, we need to be objective. And there are certain things we need to be looking at. The labial convexity to start with. Because any implant without that nice labial contour will look false. It will be shouting out, hello, I'm the false tooth. And then the zenith needs to be matching nicely. You cannot expect all implant restorations to come out from a circular zenith. The zenith of a central incisor or the emergence profile of the central incisor is completely different to the zenith and the emergence profile of a canine or premolar. And then we've got the soft tissue color, the soft tissue texture, the soft tissue level, emergence profile, and the papilla. At the end of the day, we need to know that whenever you make that decision, I'm going to start providing this patient with implant therapy, there are certain rules you have to follow carefully to be able to achieve good pink aesthetics. When it comes to implant dentistry, beauty is an absolute. It's not an option. It has to be naturally looking good. Otherwise, it's going to be failed implant. But before we talk about, advanced ways of managing the bone and the soft tissue, let me please take you back to the basics, ABC implant dentistry. ITI consensus as early as 2003, they made it clear that success in implant dentistry means trying to achieve something which gives you harmony with the perioral facial structure of the tooth of the patient and the healthy surroundings dentitions. We know that whatever we're going to provide that patient, implant patient, is not going to be real bone or real soft tissue, because we understand the biology between, the difference in biology between an implant and a tooth is huge. But we're trying to build things in a way to imitate that natural appearance. Let me share with you Jonathan's case. Jonathan is a patient who was referred to me by his general practitioner after having the upper central and lateral teeth removed on the right-hand side. And as Alan mentioned, I personally prefer to allow 6 to 8 weeks healing, and that's what we call early placement. We raise a flap, and usually whenever you get failing post-crowns, you get huge amount of labial bone loss. So we knew that this is what was waiting for us. We placed 2 dental implants in the correct position, maintaining that interseptal bond. In the old ages, we used to think we need to go for wide implants to get good primary stability. Nowadays, we understand that actually we want more bone, less titanium, especially if we're using type 5 titanium. In this case, rock solid implants, which is an alloy made of titanium and zirconia. So we like to use narrower implants in the anterior region to preserve more bone. And in this case, I'm not talking buccolingual. Actually, I'm more referring to mesiodistal, and especially that interseptal bone in between these 2 implants, because that interseptal bone is going to preserve the papilla for us. We get a membrane, and as Alan mentioned, we like to stabilize the membrane. So personally, I get a collagen resorbable membrane, stabilize it on one end with 2 pins, and then lift it back, just like sliding a curtain back, get my bone grafting, and I like to go for layering technique. We'll talk about this in a few slides. And then put the membrane back, stabilize it on the other side. I like to tent my membrane above these healing abutments. And you could see the whole idea is to make sure that that interseptal bone is well protected. And then we achieve good soft tissue closure under no tension. And from there, we leave it for about 12 weeks in the upper jaw, tiny little exposure, impression at the time of the exposure. We got our temporary restoration because yes, we managed the bone and the soft tissue surgically, but that's not good enough. Now it's time for us to go through what we call prosthetic soft tissue sculpture. Using these temporaries and gradual changing the size of and the shape of these temporaries will help us to maintain the papilla growing and also getting that nice soft tissue contour. It's so important to have a contact point. Without a contact point between the 2 temporary crowns, you won't get a papilla growing. And once we reach a point that we're happy with the zenith, with the emergence profile, with the papilla, with the soft tissue level, all the same points we mentioned at the very beginning, now it's time to go for the final restoration. And one can appreciate that when we started, these implants had no labial wall, but as we managed to build the bone gradually with a good, well-stabilized membrane, you could see how we managed to build that convexity back. And from there, we now, in the impression stage, we want to customize our impression pickups because I'm not only interested in showing my lab technician where the implants are, but I want my lab technician to get full idea of the subgingival profile, which took me about 8 to 10 weeks to build using my temporary restorations. And in this case, we decided to go for CAD-CAM titanium abutments and cemented option. And this is the convexity we're talking about. You could see how we managed to get healthy soft tissue supported by healthy bone underneath. At the time, Jonathan was 35 years old. He just wanted to maintain his diastema. 5 years down the line, he kept coming back for his regular reviews. He decided he wanted to get rid of that diastema. And all what we've done, my colleague Victoria built a nice white filling on the upper left central incisor. And within 6 weeks, the papilla start to grow between the two central incisors. If you look at the picture on your right-hand side, you could see how we've got a convexity matching the adjacent tooth. And here you could see day one with 5 years post-operatively, we've got good bone and soft tissue stability. And we've got good papilla growing between the two implants. So if I want to summarize learning points of this case, success is influenced by implant positioning. In fact, as I will show you later on, a very good review where they wanted to look at failure in the aesthetic zone. They had 101 cases where they had failure in the cosmetic point of view, and they analyzed the cases, and they found 40% of them because that implant was placed a bit too labial. We're talking about 1 millimeter or a bit more too labial will give you implant failure. We don't need wide implants in the anterior region. We want more bone, less titanium. Especially if you're using type 5 titanium, you can get away with 3.3 implants for the anterior region. If you're using type 4 titanium, then I would say 3.75 or 4.0 is good enough. And that's what we're saying, type 5. Maintain your interdental bony peaks, because these bony peaks are going to preserve the papilla for you. We understand from the work done by Atlanta team that in order to have a good papilla between an implant and a natural adjacent tooth, you need 4.5 millimeter vertical space between the crest of the bone and the contact point. However, if it's between two implants, that 4.5 becomes 3.5. So you need to preserve that height of bone, otherwise you won't get that papilla. Membrane stabilization is essential when it comes to guided bone regeneration. And then you need to make sure you spend good time going through a well-designed provisional restorations to be able to do prosthetic soft tissue sculpture. And when we talk about well-designed prosthetic temporaries, we're basically referring that everything subgingival has to be concave. So what you do, you put no pressure on the gum. If anything, you create a dead space, and that dead space, if there is a good tight seal on the top, going to be filled with granulation tissue, and that will give you thicker soft tissue labially with no surgery. However, everything supragingival has to be convex to deflect the trauma away. My colleague Victoria has got a really good lecture on 7 secrets of successful temporary restoration. And maybe in the future, Alan, you could get Victoria to talk to you about this. Really interesting concept. And then obviously contact points are essential, because without contact points, you get no papilla. Now let's remember, whether you're practicing in Washington, New York, Leeds, London, we have the same challenge. Our patients coming to us losing a tooth, and they think because they can afford the price of dental implant, they think that you're going to give them something which looks 100% similar to what they've lost. Now we do understand that having a new implant restoration going to have completely different biology to the tooth they've just lost. And we do understand that whenever we have a tooth removed, like it or not, you're going to have labial bone loss. You're going to have soft tissue recession. That keratinized mucosa around the natural tooth, non-attached keratinized mucosa, we call it the free gingiva, is going to disappear the moment we take a tooth out. So we're starting from -3 or -4. and our patients expecting us to take them to 10 out of 10. And that's why it's important to follow the rules. Now, when it comes to aesthetic implant dentistry, the rules have been set as early as 2004. This is a very good study, and I'm more than happy to share it with you. Actually, it's a very good review written by Danny Boozer, who's a very good surgeon, and Ernst Wilzer, who's a very good prosthodontist. And they put the system which you follow to get optimal aesthetic restorations in implant dentistry. To summarize it, they said, you need to focus on correct implant positioning. And that's where the concept of reverse treatment planning was born. You need to have the final end result in mind and work backward. And then from there, we talk about the bone quality, bone quantity, and then soft tissue, and then prosthetic design. That's what we want to achieve. When it comes to correct implant positioning, this is the very good review or very good study I mentioned earlier on, published in 2016, where they looked at implants which failed aesthetics, and they found 40% of these cases, the implant was placed too buccal. And that's where people look at the scan and say, wow, we've got loads of palatal bond there. This is going to be an easy case. Let's just stick that implant, getting really good stability from that palatal bond. Well, what we need to do is to focus on the position of the shoulder of your implant, where it needs to be within the prosthetic envelope. And we know that that labial plate is made of cortical bone. Now, cortical bone acts completely different to cancellous bone. We know if you want to get primary stability, ideally, you need to compress the apical 1/3 of your bone, which is usually cancellous. Cancellous bone loves compression. You compress the cancellous bone, it regenerates nicely. While cortical plate hates compression. If you get tiny bit close to that cortical plate, it's gonna have micro cracks and it will start to dissolve and disappear. That's why we know nowadays when we place implants, we need to keep away from that labial plate. And that's another reason why we don't use very wide implants in the anterior region. So essential understanding when it comes to peri-implant bone and soft tissue stability. I like to show you the dominoes effect. In implant dentistry, we have 6 major factors and they rely on each other just like dominoes. The very first thing we need to check is the palatal bond, because sometimes your palatal bond can be sort of resorbed, and then you think that you're placing the implant in the correct position, but actually you shift the implant too labial because you don't know where's your reference palatally. And then we talked about the implant, and then we need to create a space. And in that space, ideally, we like to put some bone, which will remodel into natural bone, because this bone function is to protect the implant. Hence, I will never put xenograft in the scalp. Now, on top of the labial plate, I will put completely different type of bone, which job is to create that nice convexity. And that's why I will never put allograft to build that convexity. And then we're talking about a well-stabilized membrane. We need to understand biology. We need to understand that every single point here relies on the point before. If you place your implant a bit too labial, you're leaving very little space for putting bone for protection, which means that labial plate is going to have less support. And that labial plate will resorb, having very little bone covering the implant. It's going to be easy for the implant threads to start to get exposed. This is what we need to achieve. We know whenever we place implants in the anterior region, we want our implant touching that palatal bond, not invading it, but touching it. If you touch that palatal bond, make sure there is no palatal gap. You're going to have nice labial gap, and then hopefully intact labial plate to graft on top of it. If you reach a point when there is a palatal gap, but smaller than your labial gap, you know you're going to end with a cement cement-retained restoration, which is what I would call Plan B. However, if you get a point where your labial gap is much smaller than your palatal gap, this is when you need to look back, remove the implant, and start again. Because if you continue, you know it will take about a year or 6 months even for you to get labial bone loss, gum recession. Danny Boozer and Ernst Bilzer in that study in 2004 came out with the concept danger and comfort zone. We know these are ABC implant dentistry. The implant needs to be 1.5 millimeter away from adjacent roots. Implant needs to be 3 millimeter away from our future gingival line. The labial shoulder of your implant needs to be 2 millimeter palatal to your future labial profile. These are the basic principles when it comes to implant dentistry. Now, you could go digital, you could go fancy, or you could stay keeping it simple, analog. Every single case in our practice, whether it's anterior or posterior, patient will get a study model wax up. And that wax up will then be utilized to get a suck down stent. And then we can put composite filling in that suck down stent, send the patient to have a scan with a suck down stent. And then from there, it will help us to analyze and plan the case. Or sometimes you could go digital, where you get a digital wax up, you get STL file, you get DICOM file, merge them together, get a digital wax up, and from there you could print a surgical guide. Whatever you want to do, analog or digital, you cannot proceed with implant placement without surgical guide. Gone the days when we used to accept freehand implant surgery, because all what you need to do is to place your implant 1 millimeter too wrong or 10 degrees wrong to the ideal way for you to get aesthetic failure. It is a huge challenge trying to achieve that perfect illusion. Not only that, that perfect illusion needs to have good bone and soft tissue support so it can be maintained over time. I would like Alan to share this short video just to show step-by-step of cases. Basically, this is a patient who came with a missing central incisor. Her 2 adjacent teeth were not strong enough to support a bridge. So as you will see, we raised the flap, and this used to be failing post-crown. So it is normal to have that sort of labial defect. Early placement, 8 weeks down the line, you know you're going to go there and find a socket. We clean the socket and try to place an osteotomy palatal to the apex of the root. And that's what I mean, trying to be touching that palatal wall. I personally like to go for taper implants because taper implants in immediate or early placement gives you better stability. In this case, we went for 12 millimeter length implant because you want to get stability from the bone beyond the socket. But you could see we placed the implant 3 millimeter away from the future gingival line, maintaining that labial gap, no palatal gap. And then that labial gap needs to be filled with allograft bone material. Why allograft? Because we know from very good studies that allograft can remodel into 60% natural bone within 24 weeks. However, my second layer gonna be made of xenograft. In fact, nowadays, we try to mix that xenograft with autogenous or allograft. And then you could use a membrane. In this case, we use a Nicoderm, which is a soft tissue graft, porcine soft tissue graft, but it's naturally cross-linked, so it can work as a membrane. These are the 3 millimeter pins, which can be used for stabilization. You stabilize the membrane, lift it back, put the first layer of bone, and then you proceed with the second layer of bone. This is an old case. Nowadays, the second layer of bone, we mix it 50-50 xenograft and allograft. Because we know you don't need 100% xenograft to provide stability. However, it's nice to add something which will remodel quicker than xenograft. And these are the 3 millimeter pens. We stretch the membrane and put a pen on the other side. And from there, we put another membrane to cover it nicely. And that's the convexity we want to achieve. soft tissue closure. I always use healing abutments. I never use cover screws. We can talk about that later on. And leave it 12 weeks, it starts to self-expose itself, remove the healing abutment, put a temporary crown, and gradually build the emergence profile, the zenith using flowable composite every 2-3 weeks. Take the temporary crown out, add to it, contour it the way you like, until you reach a point when you're happy with the zenith, you're happy with the papilla, you're happy with the emergence profile, and you get your final case with nice convexity. So the take-home message from this, we know now that we need a minimum of 2 millimeter buccal bone to have stable bone. If you have bone less than 1.5 millimeter, you're gonna get avascular necrosis, because there will be very little blood supply to that buccal bone and it will remodel and shrink. We know that the labial plate in the anterior region is going to be most likely less than 1 millimeter. In fact, it's going to be 87% less than 1 millimeter, and only 3% going to be more than 1.5 millimeter. Do the math, my friends. We need 2 millimeter, but we only have, if we're lucky, 1 millimeter. It tells you that most likely in the anterior region, we're going to need GBR. Now let's look at healed sites. If you're going to place an implant in the correct dimensions within the prosthetic envelope in the anterior region, most likely you're going to have a perforation apically or dehiscence coronally. In fact, if I place an implant in the anterior region and I don't get dehiscence or perforation, it's 1 out of 2. It's either I'm so lucky that I've got this 3% of my patients where the buccal bone is thicker than 2 millimeter, or I place my implant in the wrong position and I need to think twice. So nowadays, it is a rule that 97% of the anterior cases gonna need guided bone regeneration in order to achieve acceptable pink aesthetic score. Now, whenever we want to talk about the bone, my friends, we have to remember Wolff's law, which was at the early 19th century or 20th century. And Wolff's law basically states that the shape and the structure of a cell, a bone cell, usually best adapted to provide a specific function. What I mean by that, whenever we want to graft, if we graft in the proper way, this bone is going to remodel to the natural cell to provide that good function, providing we're using the right technique and the right material. What do I mean by the right technique? I think we need to fully understand when we can get away with simultaneous guided bone regeneration or when we have to go through a staged approach. The best way is to try to look at this classification. Guided bone regeneration classifications are very similar to guided tissue regenerations, and periodontists understand this very well. When it comes to implants, if you place an implant in a socket with an intact labial plate, we call it 3-wall defect, which means a defect with remaining 3 walls. We've got mesial, distal, labial. But if that labial plate is missing, we call it 2-wall defects, because we only have 2 walls remaining, mesial and distal. Both these 3-wall and 2-wall defects are considered favorable defects, and you could go ahead, place the implant in the correct position, and go on with guided bone regeneration done simultaneously. Now, for me to be able to offer my patients successful guided bone regeneration, I need to have an implant placed in the correct position. Again and again, we're talking about the importance of correct position. And then I want to have guided bone regeneration using a material which is used properly for that specific function. One size doesn't fit all. I used to be one of those who used to think that xenograft, cow bone, is the magic bone and is suitable for all types of bone grafting. Till 10 years ago, when I realized that my decision to which bone material I'm going to use has to be biology driven rather than market driven. And that's why if you open my cupboard, you're going to find xenograft, you're going to find allograft, and alloplast. And according to the indication, I will decide when to use what. And then whenever I want to use a membrane in the anterior region, in these favorable defects, I would like to use a stretchable collagen membrane. Because when I want to stabilize a membrane on one side, and then lift it back, put bone, I would like to be able to stretch my collagen membrane to the other side, stabilize it, and get that nice convexity. That's why whenever you want to look at your collagen membrane, make sure it has a stretchable properties. Alan, how we're doing with time? Do you want me to stop, take questions?
We are doing great, actually. Thank you so much. Wonderful presentation. I have a couple of questions coming from the audience here. The first one is, how about the stabilization pins that you use to stabilize your membrane? What will happen with them?
Okay, very good question. Now, medical legally in the United Kingdom, these pens considered as temporary prosthesis, which means by law, eventually you have to remove them. Now, in reality, we don't remove them unless they cause trouble to our patients. What do we mean by trouble? Sometime with time, especially people with thin biotype, these pens start to poke or start to show through the soft tissue. And then removing them is going to be very easy. 2 millimeter cut, and then just literally fleck this pen with an excavator. Because these titanium pens are made of polished titanium, so they will never integrate to the bone underneath. Yeah, another question?
Yes, perfect. That's awesome. One of the things is, I agree with you, stability of the bone graft and the membrane is the most important goal to grow bone. So whatever it takes, we need to do it. I love the idea of using the pen. There's another question coming, several questions talking about the provisional temporary crowns that you are doing over provisional abutments. Some questions were talking about the emergence profile. How can you support the papilla? How can you shape the soft tissue? So if you can share with us some of these tips, I guess some of them you do it chair side, some of them you do it with lab. So if you can share with us some of this tips and tricks, that would be great.
100%. Basically, the idea is we start with an emergence profile of a circle, which is the shape of healing abutment. But we cannot have a molar or a canine or even a central incisor on a circle. Otherwise, we're going to get this potato on stick effect. It doesn't look good. It's not hygienic. So what we need to do, that gradually we start to change that circle into inverted triangle in a central incisor example. And why gradually? Because if you go and try to get a final restoration with a triangular cross-section, try to fit it in a small circle, you're going to put too much pressure. And that too much pressure can give you pressure necrosis of the soft tissue, and that can give you more recession than what you want. So the idea is to get that temporary crown, which is made of composite, and every 2 millimeter, every 2 weeks, add 1 millimeter in the right direction. You take it out and you add 1 millimeter in the right direction, in the right shape. And by doing this, you gradual tissue sculpture. Now, this will not give you necrosis. If anything, it will just give you reshaping of that central incisor, soft tissue. Obviously, the trick here is make sure that composite is fully polished. And as I said, this is a very, it's a long topic. I think we can cover it together when we have a good 45 minutes on temporization, how to build a temporary. I'll be more than happy to go through it next time. Would you like me to continue with the second part of the presentation?
Yes, I think we are good in time. We still have almost 20 minutes to go. I already received a request from Dr. Justin Paulson. He is Dr. Paulson. He practices in Montana. He is with us at the periodontology program. He wanted to share with us one of his cases, so we can give like around 5 to 7 minutes to share his case as well.
So moving on, talking about GBR, why do we need guided bone regeneration in implant dentistry? Now, the way I like to, obviously we know we need guided bone regeneration to get horizontal augmentation or to produce ridge preservation. And at this point, I would like to, draw your attention to the fact it should be called ridge preservation and not socket preservation, because you can never preserve the socket, but this is terminologies. We do guided bone regeneration for sinus grafting and sometimes for vertical augmentation. For now, I would like to focus on the horizontal augmentation aspect. We've got 3 central incisors placed in 3 different patients. And after placing your implants, you look at the bone, and on the left, you could see we've got more than 2 millimeter bone. In the middle, it's 1 millimeter. And on the right-hand side, you've got exposed threads. Which one of these you think, my friends, that you need to go ahead with guided bone regeneration if you're placing these implants in the anterior region? Now, I used to think that the middle and the left. However, I'm going to show you why all of them need guided bone regeneration. Now, first of all, let me refer you to this very recent, very good study, 2019 by Monji et al. They showed us the importance of having thick bone around dental implants. And you could see here on the left-hand side, if you place an implant with a bone thickness less than 2 millimeter, it will take an average about 6 months before you get bone loss. Now, if you get thick biotub, you won't notice, but how you're going to get a pocket and exposed titanium, which will get contaminated, and then peri-implantitis will start. If you get thicker than 2 millimeter, studies show that you might get a bit of suturization around the implant, but you will still maintain that 2 millimeter bone thickness. So we understand that we need a minimum of 2 millimeter to protect the implant. But that's only the first challenge, because what I'd like you to notice that in the anterior region, the challenge is beyond protecting the implant. We need to go and provide that nice convexity. Now, if you're going to go as guided bone regeneration, I would like to say, it goes into 3 levels. The basic level is covering exposed threads, getting that 2 millimeter, and that's the absolute minimum. You're going to be an implant dentist, but you're not going to get beautiful aesthetics all the time. If you're after aesthetics, you need to be grafting your implants beyond these 2 millimeter, thinking about that convexity you want to achieve. But what about the third level? The third level is trying to think, even when you place an implant for a molar region, and you've got your 2 millimeter, sometimes you need even to graft more, because you want to be able to achieve a very nice wide platform to support that big molar crown and having no undercuts underneath. Let's talk about these quickly. Covering exposed threads, we just talked about that we need minimum of 2 millimeter. Personally, I will never put xenograft touching my exposed threads, because I know from very good studies that if you're lucky, you're going to get 12 to 20% bone remodeling of your xenograft after 5 years. So I want that labial surface of my implants to be covered with natural bone, because natural bone is going to fight any future peri-implantitis better. Natural bone going to fight contamination with saliva, etc., etc. While xenograft is going to be 20% natural bone, and the rest of it going to be either necrotic xenograft or very loose granulation tissue. You think you've got bone, but actually you haven't, covering that exposed surface. So personally, and this is in line with the ITI guidelines, I would like to have autogenous bone covering my exposed threads. And then The second layer going to be my xenograft and then a membrane on the top. Now, where do we harvest autogenous bond from? The easiest way is to try to use your twist drills, which are the second, the third, and so on drills, at a very low speed. We're talking about 70, 80, 100 RPM with no irrigation. And if the bone coming on the flutes of your bare, pink, red bone, you know that you haven't overheated the bone, and you could use these bony particles to cover exposed threads. However, when we looked at histology, we found that this bone doesn't have really good quality osteogenic cells. It's better to try to scrape some bone, either using safe scrapers or piezo surgery, or even just like a proper hand instruments called bone scrapers. I get them from Heath, for example. You need to sharpen it and scrape some autogenous bone. Now, if you have a huge defect where it's going to be not easy to harvest loads of autogenous bone, and you don't want to open a second site of surgery in the ascending ramus, you don't want to put your patient through that massive trauma, then you could use something which you know will convert into autogenous bone eventually. There are very good studies showing that allograft will convert into 100% autogenous after 5 years. You get some bone resorption, as Alan mentioned earlier on, about 20% volume loss, but that doesn't matter because you're only using it as the first layer in touch with your implant. The second layer going to be that ridge contouring layer. And as I've mentioned earlier, nowadays I mix it 50-50 xenograft to give me the mechanical stability with allograft to give me the ability to remodel. And that's what we do at the moment. We do cortectomy, we place healing abutments, short healing abutments. Even when we bury our implants, we put allograft as first layer and then mixture of xenograft and allograft as a second layer. So plan A, autogenous if you can, plan B, and then xenograft, plan B, allograft, and then a mixture of xenograft with allograft. By doing this, you know your implant is going to be well protected and your soft tissue well supported by a properly augmented bone. Now, the second step, you say, right, I want to be above average. I want to achieve aesthetics. And that's what we're talking about, trying to focus on building that convexity. Now you have the choice. You could belong to the Dennis Tarnow, Danny Boozer school, or you could belong to the Zucchelli school. Zucchelli believes that this convexity can be achieved by connective tissue graft. You don't need to build it with bone. While Danny Boozer and his school, they believe that that convexity needs to be built with a slowly resolving bone. And personally, I belong to that school. Hence, we build the bone, not only 2 millimeter, but sometimes 4 or 5 millimeter, build that convexity, which is well supported. And then you get a post-BCT, you could see you've got the bone you want. Whatever you do, whether Zucchelli school or Danny Boozer school, please don't just go ahead and place an implant and think, my implant is covered with 1 millimeter bone, that's great. Because that 1 millimeter bone is going to remodel, and within a year or two, you're going to get aesthetic failure. As Alan mentioned, nowadays we know from the zero bone loss concept from Lithuania that if you have thick bone, it will protect the gum above it. And if you have thick gum, it will protect the bone underneath. It's a two-way relationship between bone and gum. And that's what we'd like to achieve. Get that convexity nice, get that thickness nice, the gum will look better and it will be acceptable. And this is Ivan, a patient of mine. You could see we place an implant for him in the correct position. It's normal to get perforation and dehiscence if you placing the implant where the shoulder of the implant coming in the cingulum of your future tooth. You do the bone management, layering technique, membrane stabilization, prosthetic soft tissue sculpture, and you end with something which looks acceptable. And post-operatively, even 3 years down the line, that bone's still there. Similar case, David, 2 implants. David was a patient with perio, but it was well controlled by his dentist. And you could see we've got recession on the laterals, and now David wants to have 2 implants. We managed to stabilize the perio. We went ahead 6 weeks after the extraction, because we've got deep pockets around the laterals. They're clean, but we decided to preserve the papillae, and we placed the implant as palatal as possible within the socket. We don't go too palatal. We stay within the socket, aiming for no palatal gap, keep a labial gap, first layer allograft, second layer xenograft or mixture 50-50, well-stabilized membrane, closure, temporization, prosthetic soft tissue management and contouring. We've got the final restoration, preserving that papillae in the middle and making sure we have no recession in the lateral. Now, the third level is like, okay, I'm gonna place the implant in the posterior region where there is no aesthetic challenge. However, I don't want to keep it like this, because if I just focus on the 1-2 millimeter buccal bone protecting my implant, when I come to restore this ridge, I'm gonna have a molar with a big undercut, which is gonna be foot trap. Now, some lab technicians try to play clever, and they give you like a ridge lap restoration so you don't get that undercut, but it's gonna be a big foot trap. Ideally, what we need to do in these scenarios, graft that ridge, and then you're gonna have a restoration, which I call it a hygienic restoration. We have a duty towards our patients that we provide them with implants gonna be hygienic on the long term, so you get good stability. And that's what we do. You know, we graft even posterior cases. The third and the last part of my presentation, Alan, is what if we have unfavorable defects? Which means you place an implant and you look, you find mesial bone, but there is no distal bone. Or no wall defect. You place an implant with no mesial or distal. Or even it's a 2-wall defect, but the mesial and the distal bony walls are so further away from each other, you're gonna have struggle with blood supply reaching the middle. This is when we go for staged bone grafting. Now, when I say staged, you have the option of going to a block graft, and the beauty of that, you get better mechanical stability and you get good immobility. Or you can go for the sausage technique, Steven Urban's technique from Hungary. You get a well-stabilized membrane with particles packed underneath, which gives you better adaptation, but it's gonna be mechanically not very stable. Either way, we need to go through 2-stage bone grafting, because according to the 3D planning, this is my prosthetic envelope. If I place an implant like this into the palatal bone, I'm gonna be outside the prosthetic envelope. I'm gonna initiate recession within 6 months' time. Ideally, my implant needs to be placed like that. It has to be in the cingulum region. Now, to get in the cingulum region, I need to bulk that bone in a staged approach. Whether you're gonna use allograft blocks or autogenous blocks, ideally, this is what we want to achieve. And I'll finish with this case. Well, this is what we want to achieve. That's the challenge we want to achieve. Now, if we can make it minimally invasive, that will be even better. In the past, only maxillofacial surgeons can do such surgeries because you need to be able to harvest bone. Nowadays in UK, and I'm sure in the States, a general practitioner with good oral surgery training, doesn't have to be a proper specialty, can go and use some ready-made off-the-shelf allograft blocks. Now, this is what I used to do in the past, but nowadays we understand that autogenous blocks will mean extended surgery time, restricted graft amount of bone, because what if you need like a full arch? Where are you going? How many chins you need for that? risk of injuring neighboring teeth and vital structures, nerves. There is always risk of exposure, not even of the recipient area, but of the donor area. And you can have double the trauma, double the bleeding, double the infection. Now, this is what we do. This is what we've been doing for the last 7 years. Star is one of my patients with a missing central incisor. She came to me after 7 years of no tooth in that area. She had in Maryland, which kept debonding. And now she got a new job. She decided to invest in having an implant. As I mentioned, every time we take a scan, we like to get a scan with a prosthetic reference, because a scan without prosthetic envelope reference is useless. You could see here that we've got very little bone for prosthetic. So we went to Star and we explained to her that I could go ahead and place an implant in a compromised way. We're going to give you vertical recession and you're going to have an ugly tooth. Star was clever enough to say no. She wanted to have a well-placed implant, which can give her 10, 15 years of success. She's very young. This is what we call a one-wall defect. So definitely had to be a staged approach. So we went to Star and said we could go to your chin or we could use a human tissue bank. And nowadays we use live donors who are people, healthy people, well selected. There's nothing wrong with their bone, but they have joint problems. So they need to have hip replacement. But to fit this big titanium head, they need to cut the femur. And the femur is very good osteogenic source. So you cut the head of the femur, people donate that, and from there, the human tissue bank can give you these ready-made blocks. You do the bone grafting and leave it 24 weeks. You could see we went from 2.6 to 7.3, or 2.5 to 7.3. Let's do the prosthetic planning. You could see now we place an implant in a correct position because we've got the bone where it needs to be. So the reverse implant concept, say, right, this is the future tooth. This is where the implant needs to go. Let's create bone to allow us to place the implant where it needs to go. You remove the screw and you could see blood on the screw. It's well vitalized bone. You place an implant within the prosthetic envelope in the perfect position. Now you do your second layer to get that convexity, get that contour, well-stabilized membrane, Nicoderm soft tissue grafting. I always use healing abutments, and we use narrow healing abutments which are level with the soft tissue just below the both papillae. Because when we come to remove the temporary, you could see we've got more keratinized mucosa even above the boundaries of your healing abutment. We fit the temporary. Temporary starts with a circular cross-section, and then gradually, we start to contour it by adding composite. Temporary is important. And yes, patients have to pay extra for the temporary, but the way I sell the temporary, I explain to them, temporary is important to contour the soft tissue. They don't get it. So, temporary is important to be a test drive. They start to get interested. But then I say, temporary is going to be acting as your spare tire. If that final crown 5 years down the line chips or cracks, rather than you bouncing back to your denture, you're going to bounce back to your temporary. And they say, right, we're going to get a temporary. We'll pay for a temporary. So you could see how we open the contact area gradually to get the papilla to creep down. And then we reach a point when we're happy, we start taking the shade, we customize our impression pickups. And in this case, we're building a CAD/CAM abutment, zirconia, with a feldspathic layering technique on the top. Now, she decided to replace her composite veneer on the lateral with a new porcelain veneer. We've got screw retained restoration. We've got well maturized gum. We've got the convexity we want. And that's the convexity around the implant, matching the convexity around the central incisor. And that's our final, that's her smile line. So it was mandatory for us to get this soft tissue matching. And that's her 5-year post-op. You could see we've got the bond we want. We've got everything the way we like. Now, sorry, I'm not sure whether we have time or not to talk about digitalization of the bone grafting, but this is what Alan showed you earlier on. Nowadays, we have prefabricated bond blocks, which basically help us to do the job, get the pink aesthetics we want at fraction of the time of the trauma to our patients, and that will help us to focus on the soft tissue management. Alan, how are you doing?
Perfect. Thank you so much, my friend. Amazing lecture. I personally learned a lot actually from it. And we have our next speaker coming for the Washington Academy of General Dentistry in 10 minutes or so. So unfortunately, we don't have a lot of time.
I know. I'm sorry.
To go over this. No, that's totally fine. Do you want to take a couple of minutes, show us some of the prefabricated cases? Do you still have something to show us?
Yeah, I could, or we could take questions. I could share with you one case.
Okay.
Just
honestly, just let me tell you something. Most of the questions you answered them towards the end of the presentation. We had a lot of questions talking about peri-implantitis. I think it's really a big subject. We can discuss it later in our study club. Dr. Paulson, probably we will discuss your case on Monday. So let's give some time to Dr. Hassan to share a case from his prefabricated bone graft, and then we'll call it for today.
Okay, thank you. So basically, this is John. John came to see me with a atrophic posterior mandible. And it was important for John to have some back teeth to be able to get that back support. And we took a scan. And even on the scan, using the shortest implants we can go away with and maintaining the 2 millimeter safety zone from the ID nerve, it was evident and obvious that we need to go for vertical bone augmentation. So you could see we do 3D assessment and 3D planning. And even better, you can get all that made in a 3D model. So you show the patient what she has now and how the bone block gonna increase the width and the height of her ridge. And then from there, we raised the flap and we did cortectomy and adapting that block and shaving that block, which usually takes about 45 minutes, even in the hands of the best surgeon, to sort of harvest the block and then contour and shape the block takes 45 seconds now, and in the hands of general practitioner, because you design it, you do all the hard work in advance, and bang, it fits in just like a missing piece of a puzzle. So you leave it for about 20 weeks. It's fully cancellous block. And after 20 weeks, you could see the post-op CBCT, how we've managed to get vertical bone augmentation. And I think, something happened with the presentation. Okay, so the idea is we get the block and it fits nicely. You stabilize it with 2 or 3 screws. Okay, I think I'm back. Let me check. Yeah. And again, my screen keeps freezing. I think my computer says enough is enough. Anyway, so I'm going to show you this. Can you see it without playing the presentation?
I can see it, yeah? Yes.
Yeah, so you could see after we leave 12 weeks for the implants to integrate, and then we go through the exposure. Okay, apologies for that. And then from there, we go through the prosthetic stage. We manage, and this is the thing, we managed to place 4.1 millimeter implants and within the perfect prosthetic envelope, and we got a screw retained bridge, which fits nicely. We you could use Teflon to isolate the screws before putting composite, or nowadays we use silver nitrate plugs because they're bactericidal. And post-op X-ray at the time of the fit, you could see some cancellous bone, but then 3 years afterwards, you could see that cancellous bone start to remodel into cortical, following Wolff's law we talked about, that cells will adapt according to the function. And then if you look at the final post-op CBCT, you could see how we've got short implant 2 millimeters away from the nerve, and then cancellous bone will remodeling into cortical plate. Now, this is a case where without that vertical augmentation, she could not have implants at all because the bone was very close to the nerve. While using this vertical augmentation, it helped. So can we trust allograft? Yes, we can. And allograft, there are very good studies showing allograft is a good bone. It remodels with high percentage into natural bone. This is another case in the anterior region where we use ready-made blocks, and you could see it used to be very thin. We use the blocks, and you could see we managed to get a nice thick ridge papilla using prosthetic sculpture, and then that's a final restoration, fitted nicely, and that's his final restoration. Can we trust CAD/CAM blocks? Nowadays we have studies with 5-year follow-up of these CAD/CAM blocks showing they're reliable and predictable. But the only thing, to be honest, these studies are mainly case reports and case series. We still need more random control trials to say it's 100% safe to do. You know, we need to have 5-10-year follow-up. But in the meanwhile, I personally find it very useful to offer my patients sufficient predictable augmentation at fraction of the time and the trauma. Thank you very much, my friends.
Thank you so much. I 100% agree with you. We still need more evidence for the customized allograft bone blocks. For me, also, my experience, it's working great in my hands. So we're on the same page. Thank you so much, Dr. Hassan, for your great lecture and your participation with us at the not only Washington Academy of General Dentistry, but also at the University of Washington here in Seattle. We had almost 500 to 600 participants in this webinar from all over the globe. So thank you so much. I'm looking forward to have you more in our series and our implant study club. The next meeting for us will be Monday, April the 20th. And then we'll have a weekly meeting. We have Dr. Stephen Rasner with us on Monday. As you can see, it's an interactive session. And anybody who wants to share cases with us, we can plan it ahead of time to discuss cases. Again, thank you, Dr. Hassan. Good luck. I know you still have probably some long day with some presentation, online presentation still going. I don't know if you have done or you're not done with this online meeting, but good luck with everything you're doing. You've been doing a great job.
Thank you. Thank you, Alan. Once again, thank you, Alan. Thank you, Washington Academy and everyone for the kind invitation. And as I said, I'm really sorry that we run late. If you need to get in touch with me, this is my Instagram, Hassan_Mayhaireh. And also, if you need to have any of the articles, summaries of the presentation, we'll be more than happy to share it with you, my friends. Keep well and stay safe, and have a nice evening. Thank you very much.
Thank you so much, everybody, for your participation, and we'll see you on Monday. Have a great day. Stay safe, Hassan and everybody.